7 counties, namely Kisumu, Isiolo, Nyeri, and Machakos. So this morning, would like to do more of an audit of where we are so far on that in terms of universal health coverage, and we're going to be getting into that. But just a quick reminder that we'd like you to participate in this conversation. Let us know on the ground what is the situation. Has universal healthcare begun to become somewhat a reality wherever you are? I would like to hear what your feedback is via the question that we have asked. And has the rollout of universal health coverage improved delivery of medical services in your area? Is that something you can confidently say that it's beginning to become tangible, or is it just a document that we read on a newspaper and on a piece of paper, but on the ground it is something totally different? Later on, we're also going to be opening up the phone lines and possibly hear what you have to say. But a quick mention of the guests that we have here. We have a very, very able panel. We have Honorable John Kagushia, who's the Speaker of the Nyeri County Assembly. And Nyeri is one of the counties that had the launch of the universal health coverage. We're also joined by Dr. Swarup Mishra, also known as Arab Kiprop. He is the Member of Parliament for Keses, but also the Deputy Chair for the Health Committee in the National Assembly. Thank you for joining us. And last but not least, we are joined by a doctor who has been a doctor in a long time and a very senior doctor in Kenya, Honorable Dr. James Nyikao. Thank you for joining us. He's also the Member of Parliament for Seme. So let me start with you, Honorable John Kagushia. Nyeri County is one of the counties that universal health coverage was launched, and would like to just get a progress report from your end on what has happened so far in terms of that being rolled out.
Yeah, the universal healthcare is one of the SDGs in Africa, whereby the African continent want to achieve this particular UHC by 2063. And as a country, I think in Africa we are among the countries now that are on the forefront of implementing the UHC, with Rwanda having gone ahead of other countries. And I think for them, they are already quite stable. In Kenya, we are still having a pilot whereby we have Nyeri, Isiolo, Kisumu, and Machakos. And of course, Nyeri was piloting based on the high levels of the non-communicable diseases which are in the area. Now, the universal healthcare has improved and has increased access to the health services because after all the people are registered in Nyeri, or quite a number of people are registered for the UHC in Nyeri, most of them now find it very easy to access healthcare from government hospitals without having to pay any costs. And for that reason, we have seen an influx of Kenyans who have now sought medical services from the government hospitals. Now, this is unlike before, where most of the people would not want to go to the hospitals because they were being barred by other barriers, including costs. Now, this in itself has also introduced new challenges, whereby you have a big influx of patients who go to the hospitals. You definitely then find that there are challenges now that come with infrastructure, the facilities.
We'll come to the challenges in just a bit, but allow me to interrupt you and bring in Honorable Mishra. And as the Deputy Chair of the Health Committee, there are certain milestones that have been put in place so that we ensure that universal health coverage is a reality by 2030. Are you happy with the progress as a committee that we're making so far?
2022, not 2022. Yes. First of all, we should know what is universal health care coverage in our country, what we are aiming for. Let me tell you before I start talking. To achieve universal health coverage is a daring step. It's a noble step. It's a great challenge. Our leadership has taken a great risk, but great decision as a legacy to come. But let me tell you, I'm not saying we have failed, but if you lose a football match, you're not going to stop football playing.
You continue playing.
You continue and do better and better every day. Similarly, what is happening now, we have a definition of our own country, nation, UHC, on a 4A. Affordability, accessibility, acceptability, availability. 4A on this polar. Now, affordability is the finance burden.
Part of it.
Risk part. No burden. Acceptability, quality service. Availability, services without discrimination. And availability was all level, in the whole country, everybody, each and one, and each and every and one and all Kenyans. Now, our objective, let me talk from the objective of 2022, and then we retrospectively discuss what is happening, what is not happening, what are the strengths, what is weakness, what are challenges. We have, by 2022, the 100% essential health facility availability, number one. Number two, 100% essential medicine availability. Number three, we should have outside pocket expenditure from 32%, which is going now, to 20% reduction. Number four, we should have the health worker, as per as WHO directive, that from now we are 10 to 13 per 10,000 population. Now we should increase up to 23. Then the next is the live birth for 1,000 infant mortality rate for live birth 1,000 from 16 to 4. You understand? Then we should have increase of community facilities from 55% to 100%. Then also, the last one I'll tell you, the from 92% to 100% achievement in case of 5-kilometer radius availability of healthcare facility.
Okay, all right. Let me come to Dr. Nyikal. And what is your envisaged idea of UHC? Because we might be talking about UHC, but it might be different for different people. Access, when we talk about access, when we talk about to affordable, what exactly does that look like in your opinion?
3 things. Universal health coverage. Universal means all people at the very best can access, the other one is access, quality care at a cost they can afford or at no cost. Now then we have to look at each one of these. Are all people now able to get the services? I think the answer is still no. But if I take my county of Kisumu, I can say some progress has been made. I think we would probably say about 60 to 70%, maybe before it was less than 50, can go to the hospital because they now don't pay. But getting to the hospital and getting to the door of the hospital is not what took you there.
The question of access.
Now, so now you can then access. What about the quality of service you get? I think what has happened to us, because of systems issues that we will probably discuss later, the quality has stayed the same or has actually even gone down because of the large numbers that have come in without a commensurate increase in supplies and human resource. So, but that's not a bad thing. At least people have come in. At cost, yes. Now they come in and they don't pay. So we now will say, okay, people can come in. And if you talk of the 5 kilometer where each person should be able, I think that we are moving in that direction. Yes, there's been some success. People can go in, yes. Now we are in issue of quality.
Quality. All right.
I think there is where, at this point in time, I have an issue, even in my own county, because the challenge that more people coming in is what is now making the quality either the same or worse.
Or worse. All right, Dr. Mishra, when we talk about quality, there are several aspects that come to it. There is the personnel that needs to be trained. There is also the question of equipment and the question of infrastructure. When we're talking about the 5-kilometer access, have we begun infrastructure that is going to take care of those who are very deep in the village to at least have a hospital they can go to where they can get quality?
Let me tell you, first we divide our healthcare facility to the primary level and tertiary level. We call it high-end and then basic, essential. Now, let us first focus on primary and basic all over the country. One, thing at one time. Now, as we know, first is finance. Healthcare financing is very important. Good governance and leadership is very important, prioritize. Number 3 is HRH, human resource for healthcare. Number 4 is equipment and commodities. But you know, what is happening, we have to strengthen arms of our Ministry of Health. Of course, we are the colleagues in the National Assembly and the committee. We are working day and night how to achieve. Now, we have to increase we have to see how the wise utilization of financing. Healthcare financing is very important. And also we have to respect the Abuja declaration of 15% of our budget to go there.
Towards health.
Which we are less than that, so we have to think. Health, one thing I'll tell you, health is one profession or one sector where nobody can exactly predict how much money will be spent. Because I'll give an example, accident emergency, critical care, ICU, intra-operative complications, nobody can predict. So we don't know how many days a patient can stay in ICU for 1 day or 100 days. So those costs, we don't know. So we have to have a strong, optimistic, aggressive financing, which is maybe 10 to 15 times fold more of that strong financing. Number 1. Number 2, proper utilization of financing. Good governance and leadership. No corruption.
No corruption.
Please.
We'll come to that in just a bit. And just a quick reminder, we have at least 2 representatives of areas where UHC has been launched, and that's Kisumu and Nyeri. So you're welcome to let us know what the situation is on the ground. The phone lines will be open for that so that you can let us know and give us information. And any other area where you feel UHC possibly is making a difference or not making any difference, would like to hear from you. But let me come to you, John Kagushia. And Nyeri County being one of the pilot counties that was identified, like you've mentioned, because of the prevalence of some of the diseases that are there. What efforts and steps have been made, especially to ensure that infrastructure is in place? Because I would like to think that even before health workers come in, there needs to be infrastructure that is there. There needs to be people, foot soldiers on the ground, who are able to identify areas that require to be advanced before others.
You know, Nyeri stands in a very interesting situation because the Nyeri PGH, what we would call the Provincial General Hospital before, is a hospital that served the region. And for that reason, every person within the Central Kenya region imagined or thought that Nyeri, or still thinks that Nyeri is still the PGH, the Provincial General Hospital. Some people have referral hospitals, like what we have in Kirinyaga, we have in Murang'a, we have in Laikipia. But every other person in those areas, even after they have gone to their hospitals, would still imagine that Nyeri PGH is still higher than their hospitals. And you know, they are now county referral hospitals, all of them. So for that reason, what has been happening is that people from across board, from all the Central Kenya counties, have been coming still to Nyeri PGH. And you know, now really is a county referral hospital, just like all the other hospitals.
Right.
Now, this in itself has had a strain. Now, bring on board the UHC. And now the services which are in Nyeri County Referral Hospital are now even more accessible and more affordable. That then increases the number of people who have come there. And for that reason then, Nyeri has had a very, very huge number of patients, very, very huge, which has really strained the infrastructure that is there. I know what the governor and the team has done is that we have a hospital which is near the PGH, which is called Mount Kenya Hospital, which has now been upgraded to a higher level. And I know an outpatient block has been done in that hospital. And now there is also a new bed space, which is also being created in Mount Kenya Hospital, which is just about 3 kilometers away from the Nyeri County Referral Hospital. But apart from that, the Nyeri Provincial General Hospital, the Nyeri County Referral Hospital, also has its facelift and also new blocks which are also being done in that particular hospital. I remember in the budget for 2018-2019, the County Assembly actually removed part of the budget which had been put to cater for an administration block, and referred or reverted this money to the county referral hospital, so that we can be able now to cater for the services that need to be improved there. And we are happy because the county executive also agreed with us as a county assembly that let us put this money now in the county referral hospital. And this is seeing improved facilities and equipment that and infrastructure that is now improving.
What exactly would you say is tangible progress in your opinion? Because that might be different from what people see on the ground. What tangible improvements can we say have been made in Nyeri so far?
No, you see, first of all, as we talk, the issue of the universal health coverage is covering all the hospitals, not just the Nyeri County Referral Hospital. And what has happened is that in all the hospitals, we have new equipments that now have been purchased and have been placed there. When you go to the county referral hospital itself, we are now receiving many more cases of non-communicable diseases. We are also receiving very many cases of cancer. I'm told, I was talking to the county CEC in charge of health yesterday night, and she told me that they are having about 120 cases, that they are handling on a very regular basis. And of course, as Dr. Misra has said, this has a very serious cost implication. But when you come to the issue of the infrastructure, if you go to Nyeri General Hospital, and also if you go to also the other hospitals that are in Nyeri, you'll find that in terms of infrastructure, in terms of new bed space, bed capacity, there's increment of that. When you go to the issue of the equipment that has been purchased also to deal with the issues of CT scans, to deal with the issues of MRI, to deal with the issues of oncology issues, we have now new equipment that have been purchased and that have been placed in these hospitals. And of course, as a county, we are also doing a level 4 hospital, a new level 4 hospital in Kenya, in Narumoro.
Okay.
Yeah.
Let me come to Kisumu. Dr. Nyikal, I have some comments that are coming through here, and we have Omwami Anyongo who says that, was it ever funded in the first place? In Kisumu, over the weekend, relatives and victims of the road accidents, remember there's a road accident that took place over the weekend, were being asked 10,000 for post-mortem services. Truly UHC? That's a question from one of our viewers. We also have Dinga who says that not at all. Take my county, Kisumu, for instance. We don't have drugs in public hospitals totally. The governor, Anyang Nyongo, they say that he has issues. And again, his relatives are abroad. Does our government care? What would you say to these people in Kisumu?
That's what I said. You can reach the hospital, so then you have access. But do you get the quality? Even if you're not paying. Asking for post-mortem, for costs for post-mortem, I think that's a different issue we leave. But I'll say what efforts are being made in Kisumu and what has achieved. And I don't disagree with those people. If you look at, if you really want to talk to wholly of universal health care, you must think of primary health care, so that you actually keep people as healthy as possible, take care of take care of ailments before they need serious treatment, because then it is more cost effective. What I know is being done is the community health workers, they're making an effort to pay them. I think that's the right step to move. And then, as the speaker said, the also referral system. How do they get into the facilities? I know they are working in Kisumu on what is called a spoke and hub, which means get some facilities, level 4 facilities, to a situation where they can deliver efficient services, so that people can refer to them. And I know that in Kombewa, they are making an effort to put a theater, a maternity. I know in Ahero, they're doing the same. In Nyeri, they may even have started. Even Kombewa, there's a start has been done in Moroni and Papunditi. But these are efforts. You don't feel these efforts until they actually reach a certain level. It's like cooking. There may be very good food being cooked in the kitchen, but until you get to the table and eat it, you can't have the effect. So I don't think people can, at this time, feel that effect. Now, the issue of drugs, I think Kisumu is affected like everybody else. The policy was that a lot of drugs actually come from KEMSA, and I think that delivery has not been very efficient. So I think Kisumu, like elsewhere, is feeling that pinch. So what, at this level, what they're feeling in Kisumu, a feeling that it has not worked, is me what I would expect. And that's something we should actually plan for. That now we are not paying, many more people are coming. When they come, there is congestion. You need more human resource. You need more supplies. You need more equipment. If you don't have them, then the feeling people have, which is right, what we are seeing there, is that this thing ain't working. So their efforts are not really being felt. But I know they are trying to, the governor is trying to get the community health workers page, that they improve that, get the hubs, the 4 or 5 level 4s working. Some effort is being put there. But I don't think at this time people are feeling that effect.
That effect.
And let me just say, as Honorable Misra said, it is money, human resource. I mean, it is money, it's finance, it is people, human resource, it is infrastructure, buildings, it is equipment, how you manage this, and the referral system and information that you need. Now, if any one of those is not working, it doesn't matter how much money you put in any one of them, if all are not working, then people will not feel
the effect.
Okay. So now, in Kisumu now, I know that even the health workers are on strike. So with that alone, it doesn't not matter how much else we have done. People at this point know that they're not receiving services
in the healthcare. All right, Doctor, you want to say something?
I wanted to add the issue of the drugs. Dr. Nyikal has clearly said that there are challenges on how drugs are being disbursed to the counties. And the arrangement has been, the amount that has been allocated to the counties, which especially are piloting on the UHC, 70% of this money is actually not paid to the counties. It is paid to KEMSA. And then 30% is what is paid to the county governments to now be able to cater for all these other services and even issues of infrastructural development and all those issues that have to do also with the staff and all that. And of course, you know, the equipment that are in most of the hospitals are under the managed equipment services, which is also, again, something done by the national government. But now the problem comes to on the issue of drugs, how the drugs are released to the counties. Because what would happen is every county would have to requisition from KEMSA for drugs to be delivered to the county. And then KEMSA will go through an approval system that is also beyond KEMSA itself. This approval system has to go all the way to the parent ministry, that is the Ministry of Health. And sometimes when there's a delay, then you find that the drugs will not reach the county's hospitals in good time. And for that reason, that kind of slows down the services which are coming through the UHC. That is somewhere I think the government would need to relook at. And of course, when KEMSA doesn't also have certain drugs, of course they are a good supplier because they have most of the drugs. But when they also don't have a certain type of a drug, then that also means that the hospitals in the counties do not also receive those drugs. Yeah.
Okay, Dr. Mishra, where do we start? Because, like you mentioned, it's a very ambitious exercise to have UHC, and it has many areas that affect it. We've talked about human resource, which is the staff. We've talked about medicines. We've talked about equipment, infrastructure. But something has to start while we build the rest. What is the low-lying fruit? Is it the medicines that we need? Is it the staff that we need on the ground? Do we need, what are they called, health workers who are released? And even if you're not able to access a building with a hospital, maybe they can come to the villages and help. Where do we start?
See, we're forgetting two things. USC, we are starting not usual constitution of our Kenya. We have changed the constitution, and we have 2 levels of governments, and we are putting a USC. So it is not easy to manage, it's complex. So now to have a coordination between 2 levels of government, central government and county government, national government, and so that is one challenging factor. So we have to harmonize, revisit. the responsibilities, the power, the comfort zone, the availability, the swiftness, and all those things. Number one. Number two is, as far as the KEMSA we are talking, we have to empower the arms of ministry, like KEMSA for medicine commodities of medical supplies. Number two, NHIF, the insurance. Number three, Kenya Medical Training College. Number four, health education. Because we need more and more vibrant human resource, both medic, paramedic, and support staffs. Surely, I always say, air hostess cannot replace a pilot. So without crew, you cannot take, there's no parking there. So health is something which is very sensitive, and it is a professional sector where we need the right people in the right place with adequacy. And of course, quality and skilled. Then, I told you the financing. There was at one time, also we as committee, my colleague, senior colleague is here, Dr. Nikal, that we also in trouble because whether it should be insurance-based or tax-based, the financing. So what I am seeing now, the ministry has taken a decision, revisiting, that primary healthcare should be tax-based and the tertiary should be insurance-based, which we have to empower in a big way, and we have to do the real mathematics. Then, as far as we are talking about infrastructure, database, look, technology and database is very important. We should have, I was told, I don't know, my colleague will correct me, is it district DHIS, information system 2, is it working that way? In district information system, so for district-wise. So we need collection. If we don't know the numbers, we don't know the data, we don't know the population-wise, the disease prevalence, incidence, and so on and so forth, we cannot make
address the issue.
The address. And then the challenges. What are our challenges? What is our problems now? We have to, as I said, health worker from 13 to 23 per 10,000 population. We have to increase. Number two, voluntary health. We don't call it voluntary health workers. Community health workers, there is nothing free in this world. If you don't motivate them, if you don't pay them, nobody will work. So we don't call them voluntary. We have to empower the community level health workers. Let us start from the basic level. Number three, we have a weak referral system, which I will, if you permit me, I will tell you about this bill for referrals, both domestic and international referrals for Kenya health, our people, our patients. Number four, it should be people-centric management with a strong health system in place. Then KEMSA, Kenya Medical Supply Agency. It has three things, three components, availability of long-range products with options. You can't say, I'll treat a patient 95%. Either you treat 100% or no, zero. So we have to availability of the broad range options. Number two, delivery time with stock, prior stock. Number three is another is the efficiency at different levels of the devolved government, as Honorable Excellency, Honorable Speaker told. So we don't have to have a blame game. Everybody is working, but let us, the crisis management, to help each other, to sit down and identify and be truthful that what is our weakness, what is our problems, and then we address it as a collective way.
All right. Dr. Nikal, what do you see as the low-lying fruits in terms of UHC? Because one thing that may be the problem is that what people are expecting and what government is able to deliver. Because let's understand that this takes a long time. There are certain things that need to be put in place before we feel the full effect of UHC. But there are low-lying fruits.
Before that, I'm sorry. One thing in the county level, as my friend is here, we should have even 47 counties as percentage. What should be the health priority? What is their priority? And how much money or resources they are allocating? It should be evenly distributed in all counties. They should, and that are they allocating or not, or they are diverting the fund somewhere. So these are the things we have to be very careful. And of course, the county government and the central government has to be work hand to hand with all informations.
To make sure that they are correlated.
With transparency.
All right. Dr.
You know, low-lying fruit, but I say priority number one in my mind is human resource, because that will cut across everything else, including the management of the system. So really that is where I think we have to address the human resource. And there has to be a very serious consultation between the county government and the national government on how we manage and handle the human resource. Number two then, in my view, would be primary health care, so that the community health workers actually should start to feel, and then level 2, level 3, before you even go to level 4. If we start those and they're working efficiently, and with that, a referral system. Let's say like Kisumu, one of the things I know they're suffering from. It is very difficult now without a referral system to convince people that they don't go to Jaramogi referral before they go to the other facilities. They go there directly. Now, if you want to tell people, go away, you can't come here. Now, that is socially not acceptable, politically not acceptable. So then we have to develop a system. But if you want to develop a system, the lower level of services must be working for people not to come to this higher level. So you need human resource. You need to invest in the primary health care and do that at the same time with level 2, level 3. Level 2 is what we used to call dispensaries, and level 3 are the health centers, and level 4 are what are the district hospitals that we are developing. Because if you can get those working, you start to take the load off the bigger hospital, and that is where you actually are going to get massive complaints. Like those, when people complain to you, they complain that they went to hospital, they were admitted, they were not treated. But they don't realize that if so many people come, those are overwhelmed. So in my view, human resource is number one. Primary health care, and then level 2, level 3. Then people start to feel you on the ground. A large number of the people are people who get sick. If they could get a quick treatment, they go back. They feel very good. By the time you are admitting them, you've actually lost a lot. It is more expensive. But on top of that, we must agree that the money will be there. So finance is taken for, we must do finance, focus on human resource, do a primary health care supported with level 2, level 3. Those ones, however much it is taking us, we must just put the money to do them.
All right, let me come to Nyeri County as a practical example. Yeah. Is there enough resource being poured into making sure that human resource is available?
I would say not at the moment, because we have serious challenges with the human resource. And it's not a county making. It's a systematic issue. Because if you look at the resources, for example, that we have allocated to the UHC, you find that well over 70% would go to the drugs, and 30% is what has come now to replace what used to be the cost-sharing arrangement before. And of course, you know this can be sufficient. As we talk now, the health system in Nyeri County is gobbling almost 3 billion Kenya shillings. And 3 billion is out of 7 billion that we have in the county. So you can already see almost 50% of what is allocated to Nyeri County goes to the health care. But even then, that is still not sufficient to be able to cater for the health services and the services that we require at the county level. So there's need to still look at this issue more critically. And one of the questions that one would want to ask, and I think Dr. Mishra here raised, and I know he's also a health practitioner himself. He runs, health facilities, and so he has much more experience. One of the questions that one would be asking is whether universal health coverage would also mean free health services. like it is with the primary school education. And probably we need to rethink that so that there can still be some small cost sharing arrangement which would still help us to improve more on the services that are being offered. Because there's no need for you to get services which are universally accessible but are of not top-notch quality. Yeah, so I would say in Nyeri County, there's still much more that we need to do when it comes to the issue of providing a human resource. And of course, there are also some specialized areas where we have faced challenges, and these have been able to get it from our Department of Health. When you look at some specialized areas, like the doctors who should help us handle the HDU, the doctors who should help us with the issue of, I think, anesthetics and such kind of things, we have advertised severally, and you find that a lot of doctors who have these specialities do not want to come to the up country. Sometimes I don't know whether it is up country which is a problem. Probably sometimes they want to remain more in town.
In town.
Yeah, so
and maybe that would speak to the bill that Honorable Mishra was bringing on board and talking about weak referral systems. And there needs to be a mind shift, because you'll find that...
I needed to finish on that, on the issue of the referral, because I need to mention something. You find that when we come to the county referral hospital, which strictly should only take patients on a referral basis.
Correct.
Ordinarily, when you go to a referral hospital like Nyeri, you will be asked for the referral. But also Kenyans are also interesting. And I would say Nyerians are also very interesting, because they have also come to learn that during the day, that referral letter would be very, very important, and you'll be asked for it. And if you don't have it, you may have to go back to your sub-county to have to be referred there. Now, what people are now doing is they time and come during the night. Because when you come during the night, you know that at that point now the issue of you cannot be sent back. It is unconstitutional. And people take advantage of that loophole, and probably that is one of the areas where maybe the committee will need to look at, the National Assembly Committee. So they come at night, and then you find that there are longer queues in the night than they are during the day. And at that point, you have bigger complaints now from even the wananchi themselves that they are not receiving as good services as they should. So you find that our people have a way of going around the rules that have been set. That
is set there. Yeah. Honorable Mishra, how do we sort out weak referral systems as per your proposal of the bill?
See, we have to make a SOP, standard procedures. What should be about referrals from primary to level 2, level 3, or level 4, whatever, that we have to keep in systems. Who should be referred and why it should be referred and when it should be referred. Number one, it should be the patient, what happens, who can be treated at primary because of his psychological decision that, oh no, this is not a good hospital, I have to go to, I have to be referred.
Hospital. Right.
Or the doctors, or I'm not saying doctors, all the health workers, now availability will automatically refer the patient in spite of the provision or the facility we have. You understand? So we have to have a strong referral system in position in our country, domestically, in counties, and in the national level. Now, as so many times we discussed in the committee, now people are buying ambulances to refer to Kenyatta National Hospital or Moi Teaching Referral Hospital. So ambulance so we don't want to do that. We want to treat and empower our county. If somebody is the head of CEO of county, or like Excellency Speaker here, he will be having a great future. If Nyeri will be self-sufficient health-wise and then called as the best, the people will talk, people will tell you that this is our health is taken care. So then you are there. Now, referral system, as you know that we are moving a bill in our country, we have to, referral system has to be there, but we should not misuse, abuse, overuse the system. Like, our country, like whether it is domestic or outside, if you want our people to be more skilled, then empower the facility, empower the infrastructure, let the patients should be treated who can be treated in that health facility.
Be treated there without being referred to
either inside country or outside country. Now, outside country, what is happening? Now the middlemen, cartels are there. Every town of Kenya or Africa to that matter, big building, a small office with gadgets to how to take innocent Africans to outside the continent. So they make $2,000 to $3,000 per patient. Per patient, imagine, 200 to 300,000 Kenya shilling. Suppose I'll tell you, replacement reconstruction surgery of joints, or suppose spine surgery, advanced neurosurgery. We can do it here. Kidney transplant we are doing in 1.5 million Kenya shilling. If you send a patient 3.5 to 4 million, imagine 100 kidney transplant, how many money we saved in our country? 300 to 400 million.
Do we need then to regulate those who are going out of the country?
Yes. What we want to do, we don't say that we stop it. No. Those who cannot be treated has to go out. But one day, we'll be self-sufficient 100%. And Kenya will be destination of medical tourism and travels for East and Central Africa. 27 countries have 1 billion people. Now, what we are saying, that we have to a system through Ministry of Health, that with a proper bill in the parliament, that the people of Medical Practice and Dentist Board, NHIF, and diplomatic mission of those countries to Kenya and Kenya to that country should sit down, and then we should know who are the patients should be referred. They should be go through that Medical Practice and Dentist Board through proper channel without politicizing, through right people. Number one. Number two, we have to vet the hospitals and the doctors who will be treating our people for referral outside country or here. They should be on the panel. The Kenyans should know who is treating them.
Where are they going?
A illiterate, subliterate middleman, a broker, should not decide for the health of my precious Kenyans to go outside country. To be decided, the fate will be in that hand because of money. So that is messing up a lot of things. Pre-operative preparation, post-operative follow-up, rehabilitatory, all those things are mess up. So what we want to do, all these things we have to do in a proper manner. So referral system has to be proper. Now, we have to have an audit. Which county is referring the least? It's the best county. We have to audit. And why? And people who are referring too much, why? And we have to audit book or a yearbook. Which patients are referred? Why they are referred? And then we sit down and see what is the cause of referral. Then every day, every month, every year, we'll fill the gaps.
Improve on the regulation.
Thank you.
All right. Dr. Nyikal, we'll have to wind up because of time, so I'll need your closing remarks. But what I'd want us to do is mainly advise Kenyans. What is it that we should expect of UHC? 2022 is what Dr. Mishra is saying is the plan for Jubilee government. Is that a reality?
I think it can be done. It can be done.
Yes.
But the thing we must do is, first of all, subordinate politics to actually professionalism and science, so that when things can be done, we shouldn't bring in any politics. And so if you talk now, if you ask me where our emphasis should be, I would put emphasis on level 4, which is not even a county referral, but a sub-county hospital, which can do most of the basic things. Work this one down, starting with the primary health care, which we are calling level 1, where people are educated and so on. The community health workers are given more emphasis. Then come to level 2, which is what we call the dispensaries and the health center and this district hospital. If we can make these things work, whether it is money, whether it is human resource, whether it is drugs, whether it is equipment, put more emphasis here so that you treat people at the lower down level. That therefore means that the biggest responsibility in UHC is with the county government. And the ministry will have to really just give standards and policies and see how they work together to support them develop these systems. And people get referred because they couldn't get what they wanted at the lower level. Even at night when they are going, did they go to a level 2 and find somebody? You find that level 1, level 2 or 3 were actually closed at night. So I would put more everything. It is human resource, it is finance at a lower level, from level 4 down, and a lot of emphasis in the primary health care, where you're going to vaccinate kids, antenatal care, water, nutrition, education, so that we reduce the load. I would even close my ears and eyes whether there's a lot of noise about cancer treatment center. I would actually go back and say, what can I do to actually get early diagnosis of cancer and, where possible, prevention of cancer, than putting huge machines to treat people. The 3 people who died that brought this, they had come from the most expensive treatment centers. Scientifically, you would therefore say that those expensive centers didn't help. So why do you want to put money there?
Why invest in that instead of, preventative? John Kagushia, your closing remarks. And Dr. Nyikal says county government, there's a huge responsibility on your shoulders to ensure that that is actualized. Is that a promise you can make to the Nyeri, people of Nyeri, that this can actually be done by 2022?
Thank you. Today you put me with 2 renounced doctors. Sometimes I wish I should have been a doctor.
but you're the practical man on the ground.
You're a practical man on the ground. But of course, the issue of course, you know the roles of the executive and the assemblies. But never mind. I do agree with Dr. Nyikal to a great extent that investment in the primary health is the most important aspect of the universal health care that, or universal health coverage that we should be considering. This because at the very lower level, that's when you're able to detect even diseases even before they get to higher levels. And in Nyeri County, what I know is that the investment that is being done in the infrastructural development, especially for the level 4s and level 3s and level 2s, is considerably high. And I would say in Nyeri County, we do not have a very big problem, especially with the infrastructure at level 2 and level 3. On that basis, on that level, I know we are doing fairly well on the infrastructure. Maybe what we need to improve is the services. If you go to my village, you'll find that, for example, in my constituency, just in my ward, you have about 3 maternity wards. Unfortunately, when I look at them, 2 of them have no babies who are delivered in those maternity wards. Only in 1 where you'll find babies being delivered. So it means that, it means that in terms of infrastructural development and investment, we have done so. And it is this is one called Vangadi, which I know has quite a bit of equipment, but you find that nobody...
We're out of time, so what I need you to do is, what promise do you make to the Nyeri people?
Yes, so what promise we can make is that from the county assembly's perspective, we are interrogating our budgets very carefully and ensuring that almost every single available cent, we send it to the healthcare. And by the way, we have passed a motion that is supposed to empower the community health givers. And these ones, again, are also very, very key, as has been alluded here. And as a county assembly, we are going to be ensuring that when we are doing these budgets, this is an area where we will be able to invest a lot of money so that we have primary health care taken care of. And this way, we would also want to urge our people to embrace these community health workers and also to embrace these smaller health facilities as we empower them to be able to deliver better services to the people of Nyeri County.
All right, I'll finish with you, Honorable Mishra. You're the Deputy Chair for the Health Committee in the National Assembly. What promise are you making to Kenyans?
As a Deputy Chair and as a committee member and also as a Member of Parliament and also a Wananchi, we'll work hard as a community, as a committee, as a one team, and we'll do best of our ability, effort, and knowledge and wisdom to brainstorm and to guide our ministry, which is doing also good work, and to see a success, by the grace of God, the dream of our leadership.
Of 2022 in healthcare.
In healthcare.
All right.
And then I request one thing, don't politicize health and don't corrupt health. No corruption, don't politicize.
No politics.
We'll be there.
All right, thank you very much. Honorable Dr. Swarup Mishra, Member of Parliament for Keses, also the Deputy Chair for the Health Committee in the National Assembly. Honorable Dr. Nyikal James for joining us, Member of Parliament for Seme, and Honorable John Kagushia, Speaker of the Nyeri County Assembly. That's Political Point. It's now 8 minutes after 8. We're going to take a short break, but do stay with us. Right here on Morning Express, we have more lined up for you.